Hello, everybody, welcome back. And today we are going to discuss, as I said, a very important topic in renal pathology, which is neoplasms of the kidney. In that, we will have benign tumors as well, and we will have malignant tumors as well. Benign is thoda sa small, chota sa, so that I've decided that I'll cover in the next video. It's like in a chotu sa video other than this, but today and then we have malignant tumors, right? Today I'll be dealing the primary malignant tumor of the kidney, which is adenocarcinoma of the kidney. Then the second malignant tumor is Wilms tumor. That also I'll put a chotusa video or shorts or something like that. In that we'll cover Wilms tumor. But today our topic of discussion would be primarily adenocarcinoma of kidney. Let's just make it very short. I'll try to cover this whole thingy in like 30 minutes, max to max 30 minutes, so that you can watch this video. And if you are watching it also, and if you're watching it in 1.5x or 2x, you can primarily cover this in 15 to 20 minutes. Just we'll go very fast, not very fast also, you'll not understand, but thoda sa fast. So adenocarcinoma is also called as hypernephroma, renal cell carcinoma, and Gravitz tumor. Okay, these are the other names, but the commonly used name is, of course, renal cell carcinoma. Moving on to why is it called hypernephroma? It is called hypernephroma. Hypernephroma is actually a misnomer because it is an old misnomer. It's an old misnomer which was used in the ancient times. Now it is primarily called renal cell carcinoma. Why is it called renal cell carcinoma? Because it is an adenocarcinoma. As I said, we are studying adenocarcinoma of the kidney, right? So we have adenocarcinoma, which is arising from the tubular epithelium. Okay, this is why it is called as renal cell carcinoma. This is a carcinoma. The most common location of this, it is present at the poles. Okay, it is present at the poles. Now without any it is present at the poles. It is mostly malignant. Okay, it is mostly malignant, and the prevalence of this carcinoma is mostly in older people, which is like 50 to 70 years of age. Then what do we have? Our males have males have more prevalence than the females. So these are the common stuff that we knew. Moving on to etiology. Moving on to etiology and pathogenesis. So first we'll see the etiology, and then I'll tell you the pathogenesis. The first is, as usual, whenever we study any cancer, the very common kind of etiology is smoking, tobacco, and other comorbid conditions like, we have diabetes, obesity, hypertension, all that. So you'll write all this. This will actually, the first two common stuff in every etiology of every pathology is this. So we have tobacco as usual, we have hypertension as usual. So this is that. Secondly, we'll come to a second thing, which is major risk factors are this. Tobacco, hypertension is a major risk factor. A second major risk factor is, we are dealing with, these are the major ones first. I'll be dealing with major ones first, and then we'll be going to the other ones. So this is the first one. As I said, tobacco, hypertension, this is the primary major etiology. The second major etiology is genetic factors. In genetic factors, I'll be telling you about some syndromes and something. Please kindly listen, and if you want, you can take notes also, and let's learn it together. So the first thing that I want you guys to know is something called as von Hippel-Lindau syndrome. Okay, it's something called as von Hippel-Lindau syndrome. What is von Hippel-Lindau syndrome? It is the deletion on chromosome 3. Okay, this is a loss of, which causes loss of VHL gene. Okay, which causes loss of VHL gene. Ya to there is inactivation of VHL. Okay, then there is mutated VHL, या तो there is hypermethylated hypermethylated nahi, hypermutated VHL. These are the things that happens in chromosome 3. We have loss of VHL1, then we have inactivation, we have mutation, we have hypermutation. So these are the things which happens with VHL. VHL is, of course, smart people, you will always know that this is von Hippel-Lindau only. So what happens in there here? This genetic thingy leads us to the most important carcinoma, which is sporadic as well as hereditary clear cell carcinoma of kidney. What is clear cell carcinoma? We will study in 2 minutes, but yeah, this leads to this. This is the first genetic factor which we studied. This is the first one. First genetic factors. Second genetic factors is something called as, the second thingy that happens is, I'll tell you, there's something called as, we have trisomy 7, 17. What happens is, this say we have loss of Y, this say we have mutated, activated MET. Okay, तो we have trisomy 7 या 17 से what happens is loss of Y, mutated and activated MET. What happens after this? This actually results in sporadic papillary renal cell carcinoma. Third, you'll tell me sporadic, so you told me. What's with hereditary then? In hereditary, we have primarily and primary trisomy 7. Okay, this is hereditary. Hereditary papillary renal cell carcinoma. Okay, you understood this? Okay. Hereditary means this can also happen, this can also happen, mutated, activated MET. So yeah, first I told you about von Hippel-Lindau syndrome. In von Hippel-Lindau syndrome, either there is a deletion or which leads to the loss of VHL, either there is an inactivation, either there is mutation, either there is hyper mutation of the VHL gene, which causes von Hippel-Lindau syndrome and which leads to sporadic and hereditary broad clear cell carcinoma. Then we talked about papillary renal cell carcinoma. In papillary renal cell carcinoma, we have some things. Either we will have a trisomy 7 or we will have a mutated activated MET. If only these two are happening, this is called as hereditary. If along with that there is loss of Y gene, which will cause the sporadic papillary RCC. That is it. Okay. Next genetic factors are something called as FH. Okay. There's something called as FH. I'll tell you what that is. FH is fumarate dehydratase. Fumarate hydratase, not dehydratase. We have fumarate hydratase. We have fumarate hydratase. In fumarate hydratase, what happens is, this is a enzyme. This is controlled by very smart FH gene. So if there is an FH gene mutation, okay, fumarate hydratase is used primarily in kidney and female reproductive system, primarily in uterus. So if there is a mutation of FH, gene, fumarate hydratase, this will lead to two primary cancers, which are leiomyomas and the second is RCC. Okay, so fumarate hydratase is an enzyme which is used in uterus and kidney primarily. So if there is a mutation in FH gene, it will cause leiomyoma and RCC. Primarily, it causes papillary carcinoma. Primarily. Okay. So this is FH. The primary thing I want you to remember is this one, which is VHL and the trisomy MET1. Second, if you want to remember this, but this is not that important. Third, there's so many times there's a question that always been asked. It's like, name two syndromes associated with renal cell carcinoma. In my models only this time 2 questions was asked. The first one is von Hippel-Lindau syndrome. The second syndrome that you can actually learn, and the third number in our list is Hogg Dubé. This is Hogg only, Hogg. Hogg Dubé syndrome. Okay. We have Burt Hogg Dubé syndrome.
Dubé syndrome. This is the second syndrome. In this syndrome, what happens was BHD gene, there is something called as BHD gene, which express folliculin, it gets mutated. Okay, it gets mutated, as simple as that. BHD, Birt-Hogg-Dubé syndrome. Sorry, this is the fourth one. First one we studied was VHL. Second one was studied was MET. Third one we studied was this fumarate hydratase. No, third one we studied was that. Fourth one is BHD gene. Fifth one is there something called as MIT family. In MIT family, we have TFE3 gene. In this TFE, the 3 gene, it gets rearranged. It gets rearranged. And if this gets rearranged, what happens was, this leads to amplified RCC. Okay, this leads to amplified RCC. Okay. What is amplified RCC? We will have a papillary carcinoma, but the cells will have a clear cytoplasm. Okay. We have MIT family. In this TFE3 gene is there, which will leads to amplified RCC, which is papillary carcinoma, but the cells are having clear cytoplasm. In this, I'll tell you to only remember. If you are don't want to remember this, just remember BHD ka naam, because they can ask you two syndromes, and then remember this, and then remember the VHL one. These are all the genetic factors that is important. Moving on to the third major factor, I was telling you the major factors. The major factors was tobacco. Then we have genetic factors, and then we have a third major factors, which is cystic diseases of the kidney. We have cystic diseases of the kidney. Okay, these are all the major risk factors. Other risk factors will include asbestos or exposure to other heavy metals. Okay, that is one. Then we would have or else, if you are having exposure to petrochemical products, that also is one. Okay, one of the risk factors. Then we have, as I said, males. Yeah, as I said, we have males. Then we have obesity. Okay. Then we have estrogen therapy. All this are the risk factors of RCC. Now moving on to fatafat, so we'll move on to the classification of RCC. As I told you, just now I discussed the classification. 2-3 to I just only told. First is clear cell carcinoma. Second one is papillary carcinoma. Then we have something called as chromophobe. Then we have something called as multilocular cystic renal neoplasm. The name is multilocular cystic. Then we have CD, which is collecting duct, Bellini duct carcinoma. Okay. So we have clear cell, papillary, chromophobe, multilocular, and collecting duct, Bellini duct carcinoma. Moving on to what are we discussing? So primarily the two carcinomas that we will be discussing is clear cell and papillary, with chromophobe, multilocular cystic, and collecting duct. And there is something called as medullary carcinoma also. We have medullary carcinoma. So I will be only discussing these two in detail. These four I'll just tell you in brief what's happening there. So when we move on to clear cell carcinoma. Okay. In clear cell carcinoma, what happens, as the name suggests, we have clear cell. Means the cell is clear. There's nothing seems to be in it. And you tell me, in your history of pathology, whenever you have heard that there is a clear cell or there is nothing inside the cell, nothing is visible inside the cell in staining, what can be it? It is definitely some fat storage is there, and that's why we cannot see anything inside the cell. Exactly. If you understand this concept, you know clear cell carcinoma. If you don't, if you don't remember anything to write, just write this. There's some fat granules or some fat stored in the cells. That's why it appears clear. Moving on, this arise from PCT epithelium. Okay, this arise from PCT epithelium. Then we have, this is mostly sporadic. Okay, but as a near, there'll be no familial connection. There is familial also. Okay, then moving on to something called as, what happens in clear cell carcinoma. As I said, the most important gene which we just studied was VHL gene, von Hippel-Lindau syndrome and von Hippel-Lindau gene. So what happens is, there's a mutation of VHL gene. This is a mutation of VHL gene, which is chromosome number 3. Okay, I just told you, right? What happens is, VHL gene, I'll tell you the exact pathogenesis of VHL gene. So VHL gene is a tumor suppressor gene. Okay, what is TSG? TSG is tumor suppressor gene. TSG is a tumor suppressor gene. What happens is, there are two genes, okay, two chromosomes. In two chromosomes, there are two genes. So as I said, there is deletion of one gene. Okay, this will just make it prone to cancer. Then we have plus hypermethylation induced inactivation of second one, which will lead to complete loss of function. Complete loss of function. Okay, then what happens is, what exactly VHL do? VHL, as I said, is a tumor suppressor gene. VHL, the VHL gene, it encodes a protein. It encodes a protein part of ubiquitin ligase complex. It encodes a protein part of ubiquitin ligase complex. What happens is, this ubiquitin ligase complex, it ligases factors. It ligases stuff. It can be proteins, it can be factors. It ligases. Its basic works is ligating. Okay. Then what happens is, if there is a complete loss of function of VHL gene, there will be no formation of ubiquitin ligase complexes. What will happen is, there will be increase in level of, because it is not there, right? So there is increase in level of hypoxia inducible factor. Because this work is done, so we have HIF increase. Okay, this increase in level of HIF1. And also there is no hypoxia going on, but still there is an increase in HIF1, which is that factor. This will trigger VEGF, IGF. IGF means insulin-like growth factor. Then we have other growth promoting genes. Okay, I hope I made it something clear. So what happened was, there is a VHL gene. It is a tumor suppressor gene. We have deletion of one gene and we have hypermethylation of the other gene, which leads to the complete loss of function. This VHL gene encodes a protein part of ubiquitin ligase complex, this inactivation leads to the increase in levels of hypoxia inducible factor like HIF1. Even though there is no hypoxia, this will trigger VEGF, IGF and other growth promoting genes, which leads to neoplasm. Okay, this is that. I'll tell you the pathogenesis of papillary also together, so that you don't forget easily. So we have papillary, right? In papillary carcinoma, what happens, and then I'll tell you the growth differently so that you can compare. So this is this. In papillary, I told you one gene, right? Here, MET. Do you remember? Trisomy loss of Y, MET. Trisomy loss of Y, MET. Do you remember this? We'll continue this here. Okay, we have papillary carcinoma. In papillary carcinoma, this also has two parts. We have familial also. We have sporadic also. Okay, we have familial also. We have sporadic also. This is, what happens is, there is a trisomy 770, which leads to, as I said, loss of Y. Okay, and this also leads to mutated, inactivations, activated, whatever you want to say, mutated MET. This leads to mutated MET. Okay, which this what is this? This mutation, mutated MET, then causes tyrosine. This MET, I'll tell you, this MET is a this mutated MET is a tyrosine kinase receptor for HGF, hepatocytic growth factor. Okay, it is also called as scatter factor. So this is a tyrosine kinase receptor for HGF. So now this is mutated. So what happens? Mutated this causes hepatocellular carcinoma also, and this causes papillary carcinoma of kidneys also. Understood? This is a tyrosine kinase receptor. What does tyrosine kinase receptor do? That we have studied it in neoplasia, that in our growth system, no, we had said we had some growth factors, then we had some growth factors receptors. Okay, in this we are having stuff for the receptor of this growth factor. Okay, there was this very big of a chart. If you really want, I'll cover it in neoplasia, but I am just trying to make you remind of that we studied this. Okay, then moving on to what happens in chromophobe, multilocular, collecting, and medullary. I'll tell you something is what is the brief of that. Otherwise details I am not going. What happens in chromophobe renal cell carcinoma? No, in chromophobe renal cell carcinoma, what do we know is there is multiple chromosome loss. Okay, there is multiple chromosome loss. Okay, which leads to hypoploidy, and that's why this is a carcinoma which is majorly a collecting duct type. Okay, no, not collecting duct type, which leads it is arising from the collecting duct. Okay, this is a type of carcinoma. What happens next is we have multilocular. In collecting duct we have something called as intercalated cells. From intercalated cells, this cancer arises. Secondly, we have something called as multilocular cystic renal neoplasm. In multilocular cystic renal neoplasm, what happened was there was loss of 3p. Okay, there is a loss of 3p. That's why this happens, and then this leads to the formation of multicystic. It's multicystic low grade variant. This low grade variant of clear cell carcinoma. Then moving on to the next side, which is collecting duct or Bellini duct carcinoma. This is also associated with several chromosomal losses, which leads to the tumor. Which leads to the tumor of the medulla region. We know the medulla primarily has collecting duct, so this several chromosomal losses cause the carcinoma of the medulla region, which is the collecting duct. Okay. Then we have something called as medullary carcinoma. It is very similar. As I said, this occurs also in medulla, and medullary carcinoma, of course, it will also occur in medulla. So this is very similar to collecting duct carcinoma. But there is a difference in gross, which we'll study when we are studying gross. So without any further delay, I'll move on to the gross of clear cell carcinoma, which is important. We'll study everything in this manner. Before that, I would really like you to revise a bit. So first I told you about clear cell carcinoma, which is mutation of WHL gene, which will cause the increased levels of hypoxia inducible factor and which will lead to neoplasm. In papillary, we saw there is trisomy, which leads to loss of Y. There is mutated MET, which is a tyrosine kinase receptor mutation, which would lead to hepatocellular carcinoma as well as papillary carcinoma. In chromophobe, we saw there is there is severe chromosomal loss, which would lead to intercalated cells of collecting duct carcinoma. Then we have multilocular cystic renal neoplasm, which has loss of 3p, which then multicystic low grade variant of renal cell carcinoma occurs. And then we have collecting duct carcinoma. In collecting duct carcinoma, several chromosomal losses. Due to that, there is collecting duct of the medulla. We have that carcinoma of that. Then we have medullary carcinoma. In medullary carcinoma, this is similar to collecting duct carcinoma, but there is a difference in growth, which we'll be studying recently, now only. Now coming to the gross of clear cell carcinoma, जैसे ही I told you before also, you will have clear cells. So when we talk about the growth of this carcinoma, this is primarily solitary. Okay, solitary only. There is a unilateral lesion. I think I'll put up a second video in which I am discussing gross, like in photo wise, but now you just know the theory on what you have to write and make a notes of that. Picture discussion we will do of every picture of Robbins. I'll make sure that I tell you what I am seeing or what you're supposed to say. See, next we have, this is unilateral. This is a solitary. As I said, this arises from, you only say this arises from PCT. This is clear cell, by the way. We are discussing clear cell. So this arises from the PCT. So what you will see, we can see some variable sizes bulging out neoplasms or bulging out masses. Okay, this is distorting the renal surface. This is distorting the renal surface. Then it is, of course, this is well defined. Okay, something, there's renal surface, this is distorting the renal surface, this is well defined, this is variable and bulging out. Moving on to cut section, as usual, of everything in pathology, and like most of the things in pathology, we have gray yellow. It looks gray yellow. Okay, gray yellow because there is some lipid accumulation there. We'll see there. Okay, there's some lipid accumulation, so it is gray yellow. Then we have there are, as usual, there are some areas of hemorrhage plus necrosis. Okay, then we are coming to microscopy. For microscopy, we have, in microscopy we can see solid, trabecular, tubular patterns with interspersed, as usual, blood vessels. The blood vessels, when we had interspersed blood vessels, this gives the appearance of a chicken wire blood vessels. Okay, then moving on, the cells, as I said, they are round with clear cytoplasm filled with glycogen and lipids. Okay, this is what you have to remember. Microscopy, we had all these patterns of that we always see in the neoplasm with interspersed blood vessels. You have to remember just two stuff. First is chicken wire appearance of the blood vessels. The second is the cells are clear with glycogen and lipids. This is it. Moving on to papillary carcinoma ka gross and something. For papillary carcinoma gross, exact opposite you remember from clear cell. Exact opposite. I said this is solitary unilateral, right? Did I say? Yes. Oh no, I didn't say. Yeah. See, I said this is unilateral and solitary. Here it is multifocal and bilateral. Papillary carcinoma, no? Papillary carcinoma, this is multifocal and bilateral. Okay, this is that. Again, you can see some the cut surface. The cut surface will show papillae like pattern. Okay, like this. If you cut surface, it will show some papillae like pattern, and there will be some areas of hemorrhage. Okay, and cystic degeneration. This is not important. What is important is microscopy. Microscopy will also show papillary growth. Okay, which will composed of a core. In the core, we will have a fibrovascular core. No, 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 no. We don't have a fibrovascular core here. So sorry, guys. We don't have a fibrovascular core here. Okay. Instead, we will have a interstitial foam cells ka core. So sorry, guys. So sorry. As I said, I am also allowed to make mistakes because I am also learning with you guys. So just remember, in papillary growth, always we have a fibrovascular core, but here we don't have a fibrovascular core. Instead, we have a core which is made up of interstitial foam cells, which, okay, that. And then next, what we have next is this growth is lined. We got to know about the core, which is made up of foam cells. This is lined by cuboidal or columnar epithelium. Okay, next what do we have? The stroma, if you see here, the stroma is scanty and vascularized. This is the core, this is the lining, this is the stroma, and in the stroma you can see that there are some samoma bodies also. This samoma bodies was present in papillary thyroid carcinoma as well. But papillary thyroid carcinoma, the difference, we had a fibrovascular core. Here we have a core which is made up of interstitial foam cells. And secondly, what do we have? Can you hear me? Yes. Secondly, what do we have? Here the line is cuboidal or columnar. Okay. There we have samoma bodies. Okay. Or here also we have samoma bodies. Next, what do we have is, I'll tell you something about chromophobe, multilocular, collecting duct and medullary, but we'll only go to like something only, not very detailed. In chromophobe, what happens was, the peculiarity of I hope you understood this. We messed up thoda sa, but I hope you got the overall view. See, for gross, you just remember it's ulta of clear cell. Clear cell, so you have to remember. You have to remember solitary, unilateral, variable bulging out near the poles. Okay, cut surface gray yellow, well defined structures. You have to remember these stuff. You have to remember these stuff. Next, moving on, in microscopy, clear chicken wire pattern, clear cells. You have to remember. In papillary, the growth is ulta of clear cells, which is multifocal and bilateral. Cut surface is, hemorrhagic and cystic degenerated parts are seen. Microscopy, my papillary growth was here. No fibrovascular core, interstitial foam cells wala core. Lining is columnar and cuboidal. Samoma bodies are present, and yeah, we have scanty and vascularized trauma also. This you have to remember. Then we have something of, I'll tell you something of chromophobe, multilocular, collecting duct and medullary. Let's start with collecting duct and medullary, because I told you there is a difference here. Collecting duct, medullary. I'm sorry. Collecting duct is showing a peculiar character, which is hobnail pattern. Okay, this is shown by collecting duct. Secondly, in collecting duct, these things are arranged in glands in fibrotic stroma. This gives the hobnail appearance. In medullary, what happens was, they are arranged in adenoid cystic pattern. The glands are arranged in adenocystic patterns. Plus, we have a desmoplastic stroma. Okay, just remember these two. Collecting duct, we have hobnail pattern. The glands are arranged in a fibrotic stroma. In this, we have medullary. Medullary may we have, it is very similar, but the arrangement is, we have the glands are arranged in an adenoid cystic pattern, and also we have a desmoplastic stroma. Another thing you need to remember with medullary is that in this medullary, we have, I'm sorry, I forgot to tell you in the, in the pathogenesis, but we have loss of integrase factor 1. This is called as INI1. Okay, in this, and also this medullary carcinoma, it is increased predisposance in sickle cell anemia. Okay, these four stuff, remember. The glands are arranged in adenocystic pattern, in elastic stroma. There is integrase 1, factor 1 loss. Then there is the trait is increased in sickle cell trait, and also this thing is like, it's starting from medulla only. Moving on to the two things that are left, we have chromophobe carcinoma, renal cell carcinoma. In chromophobe carcinoma, the thing that you really need to remember is that one thing. In this, the cells they have a prominent cell membrane. They have a eosinophilic cytoplasm. Okay. Then they have a wrinkled nucleus and they have a perinuclear halo. Okay. And then these things are arranged in sheets around blood vessels. I'll draw this for you so that you can remember. We'll draw a prominent cell membrane. Can you hear? We have a prominent cell membrane. We have a wrinkled nucleus. Okay. Then what do we have? We have a perinuclear halo. Then what do we have? We have eosinophilic cytoplasm. Leave some perinuclear halo. We have eosinophilic cytoplasm. Okay, we have eosinophilic cytoplasm, we have perinuclear halo, wrinkled nucleus, and these are arranged in sheets around blood vessels. Okay. We have the blood vessels. Okay, remember these things about chromophobe carcinoma. Then we have multilocular cystic renal cell carcinoma. As the name suggests, the gross consists of multilocular cystic layer. So we have multilocular cystic. So for multilocular cystic, we have cysts of variable size, and those cysts are filled with clear, serous, gelatinous fluid. Okay, clear, serous, gelatinous fluid. Then what do we have is, these cysts are separated by septa, which is similar. It is not fibrovascular, but the septa is composed of clear cells, as we see in collecting. No, the clear cells are similar to the cells as we see in collecting duct also, and also we see in clear cell carcinoma. Okay. Just remember that. We have multilocular cysts. The cysts are of variable sizes. The cysts are filled with clear serous fluid and gelatinous fluid. The cysts are surrounded by septa. The septa is not made up of fibrovascular, but it is made up of clear cells, as we see in collecting duct and clear cell carcinoma. I hope you understood till this. We are done with gross. Now there is two more things to left. I am so sorry if this video is getting longer, but I'll try to wipe this up and wind this up in 2 minutes. For renal cell carcinoma, we have some clinical features. The clinical features are a very classic triad of features. Classic triad of features we have. The first is costovertebral plane. The second is a palpable mass. And the third is intermittent hematuria. Okay. These are the classic triad of symptoms. These are the specific symptoms that you should know. Okay. And also the thing is, in this in renal cell carcinoma, unless for the initial time, it will be asymptomatic only. Till the size of the tumor is reaching more than 10 centimeter, these symptoms will primarily occur. Okay, then we have some another symptoms as like, you know, we have something called as I said, right, once explained it to you in my previous video, that what is paraneoplastic syndrome. Do you remember that you know, I said that it is very poorly differentiated, that you know, it is starting to mimic some ectopic hormonal production is happening. This is what exactly what happens in renal cell carcinoma. And then this thing, the renal cell carcinoma, is mimicking hyperkalemia. It is mimicking Cushing syndrome. I explained paraneoplastic syndrome in my before videos. Please do see. It is mimicking leukemoid reaction. It is mimicking amyloidosis. Okay, there are so many symptoms of these also. Then there could be feminization. There can be masculization. Then there can be hepatic dysfunction. Okay, all these are happening. Okay, this is what is there. Now we have some non-specific symptoms also. You can have fever, malaise, weight loss, all that. Secondly, we'll move on to the spread. This spread is primarily, you know, something, this is one of those rare tumors which primarily spreads via the renal vein. Then it goes to IVC, then it goes to the heart, then it goes to the lungs. Other lymphatic spreads are also there. Then we move on to the second last topic of renal cell carcinoma. How is the grading? The grading is in 4 parts. We have 1, we have 2, we have 3, we have 4. Okay, 1 is the tumor cell nuclei is invisible is invisible at 400x magnification. Tumor cell nuclei is invisible at 400x magnification. In grade 2, we have conspicuous tumor cell nuclei at 400x. But it is inconspicuous at 100x. Okay, conspicuous is this, inconspicuous at this. Grade 3 is conspicuous at 100x only. But till here, the nuclei was basophilic in both of this. Here, the nuclei is eosinophilic. Okay. When we talk about grade 4, I'm talking about grade 4 here. Grade 4, the nucleus shows high pleomorphism and we can see the tumor giant cells. Okay. Then what do we have in this is something called as the prognosis. The prognosis of renal cell carcinoma is good if distant metastasis is not there. Then what do we have is treatment can be, you can go for radical nephrectomy, sorry. Then you can also go for partial, or you can go for adjuvant therapy. In this we can use tyrosine kinase and VEGF as we saw in the pathogenesis, right? We can use some antagonist of this. One thing that I forgot to tell you is a very small point, which is we have a type of renal cell carcinoma. It is also called as sarcomatoid. It is called sarcomatoid carcinoma. In this, it is the commonest sarcoma. Okay, not that important. You can just skip it. Okay. Here I am done with renal cell carcinoma. I will be covering the benign and probably Wilms tumor in the next video. In this, we have something other than this also. We have something called as urothelial carcinoma of the pelvis. That is also very small. I hope you understood that. I hope you understood the pathology, etiology, pathogenesis. I try really hard. What is this? Okay. Now, okay. I hope you have, if you liked the video, please like, share, subscribe, whatever other people are saying. Secondly, I really try to keep this video short, but yeah, if you are aiming to cover each and every point of Robbins, I think it takes time also. But I try to cover each and every part of Robbins. You can just go read it and you'll understand this. I'm sorry, my handwriting is still as bad as I'm trying to improve it as much as you say. Please, if you have anything, if you found anything wrong, if you want me to, upgrade something, so just put it in the comment section and I'll be very glad to talk to you guys also. So yeah, that's it for today. Have a great